So Ryan, now the flower's in your way. So thank you for joining us.
Thank you so much for having me.
And how's everybody doing? Is everybody having a good time today, learning a lot? Okay, we're gonna make this interactive, so see those mics over there. If you have any questions for Ryan, and I'm sure many of you will have questions, we're going to have time. So please be prepared, feel free to get up anytime, and then I will point to you and ask a question. So anyway, so I want to start off, I think, first of all, I want to congratulate Ryan because I think he's doing a great service putting all of these medical records online. So I just want to give an example because of how helpful this has been, because there's so many clinics out there that are so almost primitive and basic and simple. So with this whole measles outbreak, I had to find out whether, I just had to remind myself whether my kids were vaccinated. So I called up, my pediatrician knows me, and they said, oh, well, you have to fax that in. And I said, okay. So I faxed it in, and then they had to fax it back to me. 3 hours later, I get this form, and it's handwritten. And I'm thinking, well, thank goodness I had a fax machine. Thank goodness I still know how to read handwriting. I mean, it's really just, it took forever to get this. And so I see the efficiency. I see the efficiency you're creating. At the same time, I did get the information, and 3 hours later, but I still got the information. So I guess the question is, your EHRs, electronic health records, are helping to save in the cost, for sure, in the efficiency, in reducing the time to get information. But ultimately, the biggest benefit is probably just improving healthcare in general, so in the quality of care. So you've been doing this for 10 years. You have, access to 101 million health records? 100 million records. So what have you seen in terms of, how do you quantify how you've been able to improve the quality of care?
I think that the space is super interesting. The EHR is, from our opinion, kind of the center of the ecosystem. So we connect to the doctor, and they're collecting all the clinical data about the patient, diagnosis data, prescription data, labs, et cetera. And then Practice Fusion as an entity is not just a piece of software technology that the doctor uses, but we're connected to 70,000 pharmacies, 400 labs, 150 imaging centers. So we are the kind of the ecosystem, if you think about a marketplace where all the transactions within healthcare happen. And so we impact pretty much every line item across the board. So the company has a mission of connecting doctors, patients, and data to drive better health and save lives. So first and foremost, it is a clinical, more altruistic vision and mission-driven company. But there is obviously major cost savings as well. If your son's doctor was using Practice Fusion, you would log in, you would have saved a half an hour, or 3 hours rather, no faxing. You would have the vaccination data. All the other doctors your son sees as well would also have that data. So that's kind of an anecdotal story, and that's like a real efficiency that's probably not measured in the macro. We manage about 6% of all patient visits in America right now. And so from a cost perspective, if you take a swag at, a third of all healthcare spend is wasted on administrative. I think it's accounted in transactions like that, and we probably have our pro rata piece of that, which we're saving. But it goes back to the macro on the visit side too. There's 250,000 deaths a year from patient data not being available at the point of care. Like, what if your son was vaccinated twice, for example? And what if he has a reaction to the medication? There's also adverse reactions from the medications. There's redundant lab tests. So we candidly, it's hard to quant at it's hard to know if a patient is alive from the technology. We actually have gotten stories that I would have killed my patient if I wasn't using Practice Fusion, but to measure that across the 55 million visits last year. It's kind of impossible to know, but we definitely feel like the work is incredibly impactful at a scale that's really unprecedented.
Yeah, no, it's true. And you talked a lot about and I heard a lot of it today about behavioral change.
Yeah, yeah.
And one of the ways we can improve the quality of care is actually changing the behavior. And you're collecting all this data, and you're actually changing the behavior of the doctors as well as the consumers. So talk a little bit about how you're improving the quality of care because you're changing the behavior not of the patient but of the doctor.
Yep. So one of the things Bambi and I spoke about over the past couple of weeks was how we actually change behavior. And one of the things that came up is once you have, we have 100 million patient records, we managed 55 million visits last year. We use that data to drive population health management. And there's a lot of talk about this in the marketplace, but what we've done is we've partnered with Merck, Pfizer, all the major pharmaceutical companies, and we're doing this with payers as well. And we look across the database, we stratify it, and for the Merck program, for example, it was about vaccinations, which is vaccines, which is traditionally an incredibly hard space to see doctors change behavior. So they just really are not bought into it. They don't proactively vaccinate a lot of their patients. And so what we did is we identified who was at risk for, who hadn't gotten their pneumococcal vaccination, for example. And last year, we intervened during 6.1 million patient visits. So we identified the patients, we flagged them, and then when that patient was in with their doctor, we put the CDC protocol in front of the doctor in the chart. So we just intervened in the chart real time. And what we drove was, we saw that the doctors were 73%, had a 73% higher propensity to vaccinate and document the vaccinations about their patients. So when you talk about the 6.1 million, the 73% increase, obviously, macro change, we believe it's one of the largest population health management programs ever. We do that right now. Right now we have diabetes, overactive bladder, COPD, asthma. So this is something that you as a patient might have many indicators that should be handled by your healthcare practitioner that aren't during your routine visit. So for diabetes, a quarterly exam, for example. What we're doing is we're going further out into the visit life cycle, before and after. So we're reaching out to you beforehand, before you're even thinking about a visit, and going, hey Bambi, you're diabetic, the protocol says you should be coming in every quarter for a foot and eye exam, and the call to action is driving you to the doctor's calendar, which we manage as well. We do the follow-up on after the visit. We're able to measure both the behavioral change on the doctor side as well as the outcome on the patient side too.
That's interesting. So you're starting with the doctor side, not with the consumer or the patient side. You really are sort of, the call to action is for the doctors initially, or maybe it's behind the scenes, it's doing it for the doctors and pinging the patients and reminding them that they have to take their
So there's a couple ways we do it. We kind of have to just deconstruct it in a very simple model. Pre-visit, you're idle, likely. We reach out to you via email, and in the email, it's from the doctor. Yep. So the reality is that patients don't trust the brand of like an Aetna or their insurer. And candidly, they're not, who's Practice Fusion in the grand scheme of things to a patient. It's the doctor and the relationship. We ride the coattails of that. And when you get an email from your doctor or reach out from your doctor, it's the most important email in your inbox that day. So our open rates are astronomically high. The response rates are very, very high as well. And then during the visit is candidly our sweet spot. We just simply manage every step of it. So we intervene in the appropriate part of the workflow, whether it's prescribing, whether it's the charting part, and then we do the follow-up as well. But the in-visit part is definitely where we have the most strength today of influence.
So that's one way that you're helping consumers sort of take more control of their health care by being, sort of pushing the doctors or helping the doctors at least remind the consumers, and that's sort of moving consumers to be more into this. There's this whole sort of paradigmatic view of healthcare today, which is that consumers should be more CEOs of their healthcare, of their health, right? So what does Practice Fusion do besides getting doctors to ping their patients to take their prescriptions? What else is Practice Fusion doing to help consumers patients be better stewards of their healthcare?
So a few different things. So I mentioned earlier, kind of when you deconstruct the patient visit, today we manage the patient's ability to find a doctor online, to read reviews. So we have almost 5 million reviews about doctors online. That's more than anyone else. We know they're from the patient, as opposed to if you go to Yelp, for example, you could review every doctor on Yelp today. So they're verified to be from the patient. We have more doctor calendars online. So to the patient, they can find a doctor, be informed, read the review, and book an appointment. During the course of the visit, that record's available no matter what doctor they go to. Post-visit, so there's the EMR during the visit interaction, which we obviously handle. Post-visit on the consumer side, we send reminders to fill a drug, take the drug, refill the drug. We send reminders for the next appointment. You can log in, you can get to all your health history real time. You can get to your labs, you can talk to the doctor as well. And then what we're doing is we're layering additional services on that today. So telemedicine is something we're really focused on right now. We're really excited about that.
Yeah, I want to talk about that a little bit, but I also just want to, just back to these consumers and making their own choices, having more transparency. You're creating this transparency, but at the same time, I think that it's not so much giving them the transparency. It's sort of even. It's not that they're lazy. A lot of them just have this. They have these biases against taking vaccines, let's say. So just back to the measles outbreak. This is where I'm going. Back to the measles outbreak. So there's all these stories about people who won't take the vaccinations, right? So it's not just you can put all that information in front of them and they don't care because they're not going to take the vaccine. So I'm not quite sure if you can answer this question, but I'm curious if we're going to get all of this information from people and they're going to make different choices. Shouldn't patients have different risk profiles, health risk profiles? They don't have that today, but shouldn't they?
Yeah, so we talked about this a little bit. There's a couple things. Practice Fusion as a technology today is a foundational technology. We haven't changed medicine per se. We've made it more efficient, but we've simply taken the practice of medicine and digitized it. And so now that we have all the data, what we're doing is, especially on the patient side, I'll talk about the score part in a second, but one of the other things we're doing now is that we know what the outcome will be if you get a specific vaccination and if you don't. That makes sense, right? Okay. So if you get it, we have a tremendous amount of patients on the platform that get their pneumococcal vaccination that are in your age and gender group, and then we have ones that aren't as well. So some of the things we're working on right now is the reminders for the next appointment I mentioned. We're getting condition specific on that. And so whether it's diabetes or a mammogram, for example, we're basically informing patients not by just going, here's what a mammogram is and here's the content on WebMD, but our data scientists are basically putting together content where here's Bambi and here's Bambi's trajectory if she does or does not get the mammogram, and it's really your informed decision to do what you want. And the call to action, if you want to get it, is to simply book the appointment on the platform.
It's so interesting. So here's Bambi. So you know what my score is, and it's funny. It's sort of what my score is. I have a pretty bad score.
We have so many patients, and I have so many patients that look like you, and I'm able to string them across. I can actually predict, your quality of life and potentially length of life as well.
Well, great. So that's sort of an analogous to credit score, right? You get a house, everybody knows your credit score. Everybody knows that you've been late in your credit card payments. You go to a doctor for something and they don't know a thing about you. You said that you visit 18, no doctor will know anything about me because I've seen so many. I don't know where my data is, it's all over, but it's certainly not as efficient as the finance industry. So why is it, and financial information about yourself is probably just as personal as health information, so why is it the finance industry has a credit score for people and in the healthcare industry we don't?
I think that there's a few different reasons. I think that you only have 3 to 4 major credit bureaus, so Equifax, Experian, TransUnion, right? So when you think about the EMR database, there's 400 EMRs. So the main piece of data being the chart is analogous to the credit score. It's in 400 places that are not cloud-based, right? So it's actually in the doctor's office where it's installed. So it could be in hundreds of thousands of offices. So that's issue number one. Secondly, a score is relatively simple, right? It's the actual score with entries on who the creditors are. And so the actual extent of the data is pretty simple, where your record is composed of allergies, immunizations, diagnoses, labs, et cetera. So it's dependent on connectivity to all the labs. And let's just take that example. Let's leave out pharmacies, imaging centers. There's 4,000 labs in the country, and there's no one that's connected. We've connected more than...
There. That's what you're trying to do, right?
Yeah, we've connected more. So we've connected 450, but the reality is that's just it's 15% of the market. So while we're more connected, there's so much of your data offline that no one can get to today. It's just an incredibly complex system, and I think that's what creates the opportunity for why a lot of people are here today. But it's definitely not a 2 or 3 year change. It's definitely a decade or two journey.
Talk about interoperability. I mean, you have your own data. I guess Epic is,
Yep.
Another EHR. They have their own data. They don't talk to one another. What is your vision for interoperability? Are you building a silo? Do you see your data working, talking to their data?
Yeah, this is a subject that's obviously just somewhat of a mundane one, right? And it's just been dragged out for decades as well. So since I started in the industry, it really hasn't changed that much. And that's actually what my base skill set was when I started the company. So that's why we started off in the cloud, which was called SaaS 10 years ago. Just in a short answer, what I think is going to happen is that there's no way to roll up, let's say you're Allscripts and you have 50,000 installations. There's no way to go to 50,000 doctors' offices and extract that data out. And there's a few reasons. Technically, it's just not feasible and cost efficient. You need an army of consultants, and then the doctor owns that data as well. So this is why we built our technology the way we did. A cloud-based model it's a multi-tenant system. Every piece of data that's ever been generated by a user on Practice Fusion is within Practice Fusion right now, and anything you ask me right now, I can query real time and get you the answer back. And so I can use that data to be in service to the patients, to share their record, right, because it's online. I can use that data to drive pharmaceutical research. I can use it to drive outcomes to an accountable care organization, and we do all of the above. And that's really what the core technology needs to be. What I do envision, though, I'm not saying Practice Fusion is the end game. What I do think will happen is the major cloud-based players, like an Experian, Equifax, and TransUnion, will plug into one another. And let's say in a few years it's us, Athena, and a few other guys. Then you have the masses communicating. That, I feel, will accelerate the demise of a lot of installed technology.
That's good. I want to talk about big pharma, but just on this point of interoperability, there's a lot of startups here that are trying to build on the data that you're already collecting, and you and I touched on this before, but it's really hard for you to open up your API.
Sure.
You don't own that data, so it's hard for you to share it with a lot of these startups who could get a huge head start if they could just have access to it. So it's something that you actually can't open up to them, right?
Well, we do open it up. One of the challenges with an open API in healthcare is that, let's say you have a patient record and it has all the data I just talked about, allergies, immunizations, meds, labs. Just think about opening that up. Where does the consent need to be, right? So is Bambi consenting to her record being shared? Is it identifiable or not? Is the doctor consenting as well? So challenge number one, explaining what this third-party service is and why it's consuming your data. The second issue is that the value of the data is different to different parties. And so what I mean by that is we send super bills, so CMS 1500s to billing companies, and they might pay us a nickel to process that because we drive efficiency to their business because they only have one API to connect to instead of thousands. That same record might be worth $10 or $15 or $100 to a pharmaceutical company that's doing research. So the economics are case by case, and when I look at the market, there's no way to deconstruct. It's really difficult to categorize all the different healthcare startups and go, what's the data worth? Rev shares are really gnarly, especially with the small company. It's like, are you going to audit financials? How is this going to work out? So we do open the data and we do share it. And so the lab connectivity is a great example. The billing connectivity is a great example. We are working on the ability, you'll see very, very soon, Practice Fusion will have the ability to let anyone connect and interject data into their dialogue. So whether you're a quantified app, whether you're a clinical decision support tool, whether you're a transcription company, you'll be able to communicate, pull a record, and then have a dialogue with our system and basically intervene with the doctor and then populate the chart as well. And then we will start chunking off different pieces of the chart to be available as well. But the biggest challenge is, the reality is that to expose an API probably costs an enterprise like ours $250,000. So when you do that, then there's the BD part, the contracting part, and doing that at scale. We're just not powered on love, right? And even though we've raised $150 million to achieve what we have, we've been actually quite underfunded. I think it's more of a $250 million exercise. So we have to be super selective about who we're partnering with.
Is that going to be raised during your IPO this year?
No, I'm saying I think in an ideal world. I think we were super scrappy and we bootstrapped. But I think we're good to go on cash and for the next. But
the IPO is this year. Everybody's talking about it. You're talking about it.
I cannot tell you that.
You will talk about revenue,
That was good.
though.
That was good.
But did you choose your ticker yet? That's always a. It's a PF.
I think you can look that up
PR,
yourself.
Yeah. Okay. So you did talk about how it's interesting. You talked about the data, and you talked about how, well, pharmaceutical companies like to pay for it. So that's actually one of your fastest drivers, revenue drivers, right? Is sort of data collection and selling that to pharmaceutical companies. So my question, so you could first say yes or no, but my question is, what do they want? What kind of data is pharma looking for? And what are they using it for? Is it to sell
I'm happy to answer
more
that.
pills?
So there's a I think there's a belief system that Practice Fusion is largely one of the biggest revenue line items is media and ads, and it's actually not. It's actually one of our smaller ones. So while it was large when we started, it's grown over time. But platform connectivity, so the connectivity to the 450 labs, to the imaging centers, has grown at a faster pace, as well as
that's an 8-figure business and your cash cow. You said, right?
Yes, thank you.
4.5 million prescriptions. There's money there.
Yes, and then so exactly, the prescriptions, the labs being sent, the population health management programs and the data are also growing at a faster clip as well. And so the data, to answer your question, we have a product that is, imagine looking at a stock ticker or the NYSE. You can pull up any drug, and it's pretty much a freemium product, and you can track real time what the drug's performance is. You can see how it's tracking against other drugs in its category. If it's losing market share, we can actually tell you who you're losing market share to. And if you're gaining it, we can actually tell you that as well. So that's available, Practice Fusion Insight. Everyone can go check that out. It also does a number of other things. So there are standard questions that pharma asks, so like treatment flows, what drug was the patient on before, and then what was the health of the patient on that prior drug and on my drug, has it gotten better or worse? So that's a standard product as well. We monetize that. So we do a lot of market research, but we're doing right now a lot of HEOR, so health economics and outcome research, and RWE, so real world evidence. And so effectively, RWE is really a clinical trial in a very controlled way without all the protocols and overhead. It's like 30% of the work. And so effectively, if you want to see, a great example is we recently had an anti-obesity drug, and if you wanted to track that drug over a year in a trial, it would be a tremendous cost. But what we were able to do is look back at our data, track that drug, and track the lab values and the weight of the patients taking that drug, but also do a comparative effectiveness study against another drug. And that data allows pharma to get more specific about who this drug should be used on. And in this case, we discovered patients that were taking the drug versus the competitive drug had much better lab values, so their A1C dropped significantly more. That's powerful data for the patient and the doctor and the pharmaceutical company.
For sure. We have 3 minutes. Does anyone have a question out there? I'm sure there's questions. You have to come up to the mic. Can you do that? Or I guess walk a few feet. So, okay. Is that the mic on over here?
I'm right here. You can just ask me. It's good.
Okay.
Hi, how's it going?
Thank you so much. I'm Dr. Lawless Archidam, I'm a general
Good to be.
surgeon, and for the past 2 years, I've wanted to make the leap and have an EHR system in my office.
Sure.
But there is so much plethora of information out there in terms of what to choose, and I've looked at least 10 systems, and I'm confused as to what to choose. It's difficult in terms of the cost of implementing it and the efficiency issue. A lot of studies are showing that if I do implement EHR, it's going to reduce how many patients I can actually see in my office, initially for the first 6 months, until I actually get up to par. So can you address a physician who's in this dilemma, how to go about?
That's great. Can we say it for
I gotta
the
dust off my
cameras?
sales pitch right now?
Yeah, it's your sales pitch. Why should he use Practice Fusion? How much does it cost? And what's he going to save? Great question.
And so I think when we tend to get on these dialogues and have a conversation on stage, we're not myopic. We're very macro about what the power of an EMR can do. But the EMR is really a means to an end. Once you have all that data, you can save lives, you can drive better population health, you can drive better outcomes. The EMR itself, though, why we've been really successful, and to answer your question, is that we offer a product that it's obviously cloud-based, as I discussed, so it's totally on the web, nothing to install, nothing to manage, so that somewhat addresses some of your implementation issues. So you can basically start today. You can effectively, we'll validate your physician today, You'll be connected to 70,000 pharmacies today. And then on the lab side, you can be connected to labs within a few days, on the imaging side as well. So all that integration that a typical vendor would do on site, that's simply turnkey for us. The product is totally free too, so that's kind of one of Practice Fusion's claims to fame. We never ever charge the patient or the doctor. We're basically monetizing the rest of the value chain, which we view that they benefit more from the doctor's decisions than so effectively, there's no cost as well. Any EMR, it's a new tool, is going to slow you down. It's just the reality of it. And so effectively, it's, how quick can you get trained on it? How quick can the staff get trained on it? And is the EMR really right for your specialty? The tools in it, the flow sheets, the templates, and we're pretty diverse. It's always case by case, so a lot of it's preference too.
What's the average doctor's clinic? I mean, how many people are in there? And then over several, I mean, you've been doing this for at least in earnest for 5 years. So when can they recoup that value, and what are they saving?
Sure. So 80% of the market is in offices of 9 or less. So the average doctor market is really about 5 users in the practice, and they usually can be up and charting. Realistically, they're up and charting in a week. So we track all our cohorts. One of the other benefits of being a cloud-based system is we know who's actually using our system and who's not. And we see that the fastest users will enable in a few days, start doing some migration. There's no good tools in the market. There simply is not to take paper charts and make them electronic. So what people do is they run them in tandem for a little while. And then for us, about a month after the user is effectively independent, scheduling with the system, charting, and good to go and proficient with it. Most other systems, because you go on site, there's hardware, software, there's connectivity. You're probably looking at 3 to 6 months as the average data, and that's something that's worked really well for us.
Are you sold? No, kidding. Okay. So, all right, he could talk to you later, offline.
Just a side note, the last conference I was at, there was a phone call in the audience while I was there, and after the doctor walked up to me, he's like, "Oh, I apologize for that. I actually signed up for Practice Fusion while you were talking, and one of your account managers called me real time."
Yeah. That's great. That's great. Okay, so 2 quick questions. I'm sorry, just 2 quick ones.
Really interesting conversation. I'm curious about the data side of things, especially on the patient side. You were talking about the complications in regards to patient privacy and not having open data, yet it also seems like your main revenue source is giving that data to pharmaceutical industry people. How do you maintain privacy on that side? Like I don't know that I want my doctor telling a pharmaceutical company all of my prescription history. How does that work on the patient side?
Yeah, that's a great question. So any data used internally by Practice Fusion and any of its partners is, unless it's for treatment, it's de-identified. So your example of your doctor sharing your data with a pharmaceutical company, we've never done that, and that we don't do that on the doctor end as well. For research, so when we do use the data, so the times where we share the data is for treatment, administration, and billing, right? So we share it with the biller, we share it with the staff members, and we share it with LabCorp Quest in the pharmacy where you'll be having your drug filled. Internally, we have a separate database, and it's fully de-identified. And so when pharma buys our data, HIPAA requires that there's 18 pieces of data stripped from your record. We go a little further than that. And then anytime we touch the data, a statistician has validated and certified that data is truly de-identified as well. And what we do is we then do the research on that de-identified database. And so it's, statistically supposed to be impossible to re-identify that data.
Answer the next question in 15 seconds.
That's impossible.
You question in 5.
Sure. I think it's great where you're going with population health and data analytics. And I know a lot of EMRs have started on we're around billing. But I'm just curious, one of the frustrations of providers is that it takes them away from the patient. They don't really focus on workflows, and there's too many clicks. And so I was wondering if you're doing anything to really go in that direction, to make it more with workflow and timestamp data so they can do performance improvement.
Sure. I only have 15 seconds, so I'm going to give a much blunter answer. Billing sucks. If anyone here is doing billing, I highly recommend not doing it. It's a really hard business. It's super saturated. There's 400 billers out there. The market's 95% saturated. Costs are super cheap for a doctor. I can get a billing system for like $100 a month. And so we basically have streamlined, and we're still optimizing the handoff. And we're one of the unusual EMRs. We're not connected to any we're not doing any billing Practice Fusion has no billing functionality natively, so we basically hand the super bill off in a very clean way to the major billers out there. And so we've streamlined the super bill creation, but everything else, we feel the market's quite entrenched, and we found that it's super difficult to get a doctor's staff members or billers to move onto Practice Fusion or just any billing system, because they're not the doctor, they're the decision maker for a different tool, which is the billing system. Does that make sense?
Okay. Oh, okay, we can't answer that question because we
Let's
have
connect offline.
Okay, yeah, do that offline because we have, actually, we do add buffers, but this is, this conference is about lessons learned too in education, so I can't let you off the stage without at least, addressing the startups here who are all trying to get started. You've been at this 10 years, you've built up a great network of physicians, doctors, so tell us, what is your advice to them? How do they get their first 1,000 doctors' offices? Those are always the hardest, right?
Yeah, so we were, that's a really good question. So we were super scrappy. It's actually one of our core values. So if you walk through the Practice Fusion office, there's a number of stories. I crashed a motorcycle and got a settlement check, and I used it to make payroll when we were going out of business. So the scrappiness it was very roll up your sleeves, the mentality. On the PR side, we saw a tremendous amount of success. So it was that brand awareness. So what I would do is anyone writing about healthcare, I would collect their information online. I'd scrape the entire web, and I built a list. And when we had something that we thought was meaningful, which was the release of the product, when we hit 100 users, which in hindsight might not have been a major milestone, we were constantly basically making the journalist aware of that, and we just built up that inertia and momentum. And when you guys think about for those of you that do know Practice Fusion, why you know us, it's not from AdWord campaigns and probably not from events, it's usually from these articles. And we were really, really good at creating, just getting that mind share and creating that inertia. So that was really key. Sorry. And then
Ryan wrote a lot of those initial press releases, right?
Yes, I did. Yeah, I wrote the press releases myself. And then, we did a tremendous amount of work around, I just cold called everyone until we had doctors. So I've done most positions in the company. So I've been a customer service rep, I've been an account manager. We used to be on the phones demoing to the doctors every day. And so that allowed me to be super agile. We weren't originally free. We were free and $50 a month for support. And one day a doctor was on the phone with me and he's like, I'll give you $25 a month. And I'm like, you gotta be shitting me. This is we're arguing over $25 when the next system up is $30,000 at the time. And he's like, there was no mandate at the time. There was no meaningful use. So he was like, I don't care, I just won't get one. And so the next day we were like, let's test this for free. And we had 20 people in a webinar and everyone went haywire. We had 18 people sign up. And we were like, let's do this. So the ability to be agile, take that data and not be hypercritical about it, but to make fast decisions was helpful.
That's great, Ryan. I'm sure we can continue this conversation, but I think he's going to stick around for a little while. So everybody, please, let's give a round of applause. Thank you.